Good morning or afternoon, everyone. It's a real pleasure to be here for an in-person Grand Rounds. Not quite as big as the prior Grand Rounds used to be, but I'm told we have quite a big audience online as well. It's a real pleasure to chair this. And I'll just... Peter, it's not working. It's a pleasure to have IT issues. Always.
I think they're right here, Darren.
All right. I'd just like to acknowledge traditional owners of the country on which we're meeting and pay my respects to their elders, past, present and emerging, and our appreciation. As you will know, I'm Bruce Mann, surgeon, breast surgeon, academic breast surgeon in the precinct. General housekeeping for everyone to read, and we are interested in lots of feedback and questions. They can go into the chat for those online, and we'll have time to address them at the end. It's my pleasure to introduce Michael Gnant, well known in person to many of us and by reputation and achievement by everyone. Michael, I must say I like it that it is a breast surgeon who has led the Austrian Breast and Colorectal Cancer Study Group and an enormous achievement, productive work over decades, particularly in the fields of optimizing breast cancer and its adjuvant therapy and in endocrine therapy. BCT here in Australia have appreciated working with Michael and the ABCSG for many years. He's also co-chair of the St Gallen International Consensus Panel. Michael was last here at the BCT in Australia at the BCT meeting 2 years ago in Cairns, and he tells me that he was also here just after this building opened some 10 years ago, so welcome back. We're going to hear about optimised management strategies for early stage HER2-positive breast cancer. I'll hand over to Michael and there will be lots of time for discussion afterwards. Thank you.
Yeah, good afternoon. Thanks, Bruce, for the very kind introduction. It's really wonderful to be here with old friends, or actually the long-standing friends, Bruce and John, and some of the others. I'm always thrilled when I'm in this building because, you know, in terms of architecture, it resembles the excellence, the research that occurs here. Here are my disclosures. This is where I live. No, actually, it's not my house. It's the house of my plastic surgeon. So in Vienna, and basically, Bruce kindly said, was talking about the achievements. I mean, I'm just the face of a wonderful team of people, and the real achievement is the achievement by the Austrian patients. I mean, it's a tiny country in the heart of Europe, just 9 million, a little more than Victoria, but we have wonderful breast cancer patients, 30,000 of whom, meanwhile, have contributed to randomized clinical trials by our group, and that's why we are a little bit bigger than on the map and not an individual person. It's also one of the reasons why the famous St. Gallen meeting moved to Vienna 10 years ago. This year we were able to welcome 3,500 people from more than 100 countries, and that's considered the largest MTD in the world with 80 experts, obviously including Prue and Shireen from this institution, and trying to transform knowledge into benefit. So it's an opinion-based recommendation meeting, and it ends in the usually quite frequently cited guideline or recommendations by the St. Gallen panel as published in Annals of Oncology recently. So today I will discuss risk of recurrence in hormone receptor positive, or how we call it nowadays, luminal breast cancer, particularly identifying high risk. That includes some of the latest updates of pivotal trials, Monarchy and Natalie. I will try to put the results in perspective and then maybe speculate a little bit where do we go from here. So luminal breast cancer, everybody knows, is characterized by different relapse pattern compared to the reputatively more aggressive subtypes HER2 expressing triple negative breast cancer. So in the light blue, you see those 5 years. In textbook knowledge, it says, if you remain healthy after triple negative breast cancer for 5 years, then you are cured. I was claiming that until I had my first patient relapsing after 5.5 years, and now I keep saying 6 years. So it may not be an individually accurate assessment, but yes, the majority of patients is well off after 5-6 years. And much to the contrast, in our perception, less aggressive luminal subtype, in that subtype, actually more than 50% of recurrences occur after 5 years. And we looked at this on a nationwide basis once, and actually in year 11, the luminals catch up in terms of relapse with the triple negative and HER2 overexpressing breast cancer. So how do we identify high risk? Yeah, we keep talking about biology and beta denominators, and every time we have an innovation, it's down to nodes and to tumor size. And just a couple of days ago, I was discussing potential new trial designs also with industry leaders, and ctDNA and other endpoints, and everybody said, well, but we need to go to the FDA, and we need number of nodes, and we need all of that. So we're kind of stuck in that a little bit. And yes, the interesting thing is that in addition to biology, anatomy matters, particularly also for the luminal breast cancer in the long term. So this is Hong Xiaoban published on behalf of all of us, putting our data together in Oxford, in the New England Journal of Medicine. So, and we know that 15 or 20 years after the initial diagnosis, the relapse risk is still defined by the baseline anatomical considerations. If you combine tumor size and nodal status, you see that after 20 years. And to me, that's still an unresolved mystery. Maybe today you can educate me. Because our common understanding is that where is the enemy hiding? Okay? Tumor cells go to a state of dormancy, they might be quiescent. Where is that? Potentially in the bone marrow niche somewhere. That's what people like myself believe. And eventually they wake up. But if such a dormant tumor cell, stem cell, putatively, wakes up, how does it remember that it originates from a 4 positive node disease? Should be very much the same, but still the inner programming somehow, at least clinically, what we see is that the annual relapse risk in year 21 is still defined by the initial risk factors. Whether that's just coincidence or a causal relationship, I don't know, but maybe we can discuss this. And because of that pattern, we obviously trying to extend the treatment duration, and that makes a lot of sense. I mean, when we treat hypertension, it's not that we find that it's politically incorrect to have high blood pressure, because we treat it because of the risk involved with that. Cerebral hemorrhage, myocardial infarction. Nobody treats hypertension for 3 years and stops after 5 years. So it would be logically to, as long as the risk persists, the risk being metastasis in luminal breast cancer, we would continue treating. However, as you know, there are limits to that in terms of side effect, tolerability, and obviously also to cost. We did that. That's about 50,000 patients on this slide. So after 5 years of tamoxifen, the extended duration works, as is indicated by the hazard ratio here is in green. It's a little bit less convincing when you use an aromatase inhibitor in the first quinquennium. And actually not everybody benefits. And again, we are down to risk. So that's the Oxford data for node-negative disease. There's almost no benefit, 1 to 3 nodes, modest benefit. And again, for 4+ nodes, is basically driving the whole story in the Oxford overview. And some of you might remember that the The Austrians did trial number 16, 7 versus 10 years of treatment, published in the New England, and there was no difference. And yes, that is a population of patients with a tendency for low risk, but there's more than 1,000 node positive patients in there. No difference in the recurrence. However, there is an adverse difference, of course, in fractures in this trial. So if we are not successful, we may actually harm our patients. And the Sagan panel already in 23 accepted this risk-based definition of the increasing treatment duration, stage 1, 5 years, clear majority, stage 2, node negative disease. You see the sentiment shifts a little bit towards 7 to 8 years. Stage 2, node positive. Now it's a clear majority for 7 to 8 years. Some panelists even voting for 10 years, and in stage 3, the majority is at 10 years. So that's, I think, pretty well defined. Treatment duration will be an issue with some of the new endocrine agents, and hopefully we can also discuss this. However, in the risk definition, it's not only the number of nodes that matters. I mean, that's the Flatiron data many of you might have seen already. So this is only N1, but N1 high risk as defined by biological determinants. And you can use multi-genomic assay, you can use Ki-67, you can use grading if you have excellent quality pathology. And you see that within the same nodal risk group, patients with adverse biological tumors with adverse biological features would actually have more than twice the relapse risk. Grade is also important. In my practice, I enjoy the privilege of having great pathologists, so we rely a lot on it. Hopefully, in the future, our determinants of risk will be a little bit more modern. I believe in circulating tumor DNA. In principle, after having played around for 3 decades with circulating tumor cells, I think that's not going to be the solution eventually. ctDNA is now moving from where we are using it in clinical practice, which is defining the mutational status in liquid biopsy in metastatic disease, but it's moving to the early breast cancer setting. And maybe someday in early detection, imagine we could identify with a plasma-based test who needs to go to an annual mammogram, and millions of women being tortured, potentially unnecessary. So we're going to see where that leads in the future. This is I-SPY data, initial prognostic value of circulating tumor DNA. And as you can see, there's a pretty reasonable differentiation between risk groups based on being negative or quantitative low, medium, high in ctDNA. And we have papers coming out every week, more or less, nowadays. And the assay is becoming more and more sensitive. I will tell you that we started a trial on ctDNA negative patients. We were struggling in finding ctDNA negative patients because the threshold, is just more sensitive with these tests nowadays. So, shifting gears to adjuvant CDK4/6 inhibitors, it's trivial to tell you that CDK4/6 inhibitors are now established standard of care in the treatment of metastatic luminal breast cancer, in addressing cyclin D1, cyclin D2, essentially being cytostatic drugs. Manufacturers don't like to hear that, but that's their way of a mechanism of action, and pretty well established in guidelines, in everything. Even when you look at the structural differences, you have the feeling that you can visually see something. So CDK4 and 6 are differentially expressed. The new generation of CDK inhibitors now, much to my surprise, it's the CDK4 that moves ahead in clinical development. I would have expected CDK2s, but anyway, that's what the decision was, obviously, in the big companies. Abema addressing, other CDKs as well, and, that's good. Monotherapy activity compared to the others, and bad at the same time, because that's also causing the diarrhea. NCCN standard, ESMO, clinical benefit scale, both in the advanced and early setting, pretty much defined now. Now, just a reminder, not for the experienced colleagues, but I think, we sometimes when we discuss these wonderful clinical trials, and then we will say, let's not do a cross-trial comparison. and we will keep doing cross-trial comparisons. So to remind ourselves, hazard ratio, relative, and absolute benefit. So imagine we had a breast cancer treatment with a hazard ratio 0.5. We do have these treatments in triple negative in HER2, not really in luminal breast cancer. And then you apply this risk reduction, cutting in half the risk of relapse to a baseline risk of 50%. That means an absolute difference of 25%. Now, if you apply the very same benefit to a baseline risk subpopulation of 90%, you will only see 5%. So comparing absolute differences is not a very wide thing. And the magnitude of the absolute difference is something that we have become carried away after the initial presentations of Monarchy and Natalie. I ran into a discussion with some of my friends, and everybody was complaining, oh, it's only 3%, it's only 4%, only 3.5%, you're not negative, it may be 2.8%. And then I said, guys, are you using aromatase inhibitors as standard of care? What's the absolute benefit of AI over tamoxifen? It's 1.9%. What's the absolute benefit of adjuvant chemotherapy in luminal breast cancer? It's not more than 3%. So this is a matter of our success. We are crawling towards cure. It's like the frog always dividing the distance to the wall in half, never reaches there, and the individual steps will become smaller and smaller. And for the adjuvant CDK4/6 inhibitor trials, I borrowed this from Hal Burstein. This is the underlying risk of the control groups, the control arms in these trials. In blue, Penelope B, Monarchy, Natalie, Palace. So they are different. Not surprised that some of the results are different. A surprise that was, and actually it was very disappointing to me personally, because some of you might know I was one of the global co-chairs of the Palace trial, and you work for 10 years and you spend about 300 million of someone else's money. That's good. And we built a network of 100 centers and 5,000 patients donate their data and everything. And then at some point, you get a call from the statisticians about the primary endpoint, and the trial is negative. I say, you are kidding me. But that's what actually has been confirmed. So palbociclib is not working in the early breast cancer setting. And later on, we had some results that also in the metastatic setting, there might be differences between the CDK4/6 inhibitor and Monarchy and Natalie. These are the initial readouts. In the beginning, I was cautious because there was also an early separation of the curves in Penelope B. And I discussed a lot with Stephen Johnson after his initial presentation. But what we saw, so the palbociclib trials, all of them negative. And that's not true for the others. Speaking of the others, it's not only Abema and Reboot, there's also palbociclib, Chinese agents for unknown reasons. Our colleagues at the ESCO committee hit that 5,000 patient phase 3 trial in some secondary session at ESCO. I'm not claiming there might be political reason, but just because it's from China, it's not necessarily not an excellent trial, excellent early result, very comparable to what we have seen with the others. There's a fourth CDK4/6 inhibitor, Tibremsiclib. So we need to open our eyes also to what other parts of the world actually do. Oops, now this is stuck. You see, I start talking about China and the slide advance doesn't work any longer. Big brother, can you help me?
Yes, I sure can.
Software.
Always a software update we can try.
Wonderful, thank you. So Monarchy, that's trivial to you. Addition of abemaciclib for 2 years, 150 milligram continuous dosing. And that was the most recent result at ESMO in Berlin. And this is really significant because it is one of the rare times when we see a statistically significant overall survival benefit. Whether that's 1.8 or 1.7, personally, I don't care so much. Obviously, the significance matters. But what I find most reassuring as a person with adjuvant clinical trials is this is 2 years of treatment. So treatment ends here. And we see 5 years later, we still see the benefit. Actually, these curves keep separating. As a matter of fact, it's reminding me most of you are way too young for that, but there's an old Swedish trial, 2 years of tamoxifen versus placebo. After 25 years, they see an overall survival difference with a treatment that from today's point of view is completely outdated. And I feel, and maybe it's because I'm a surgeon by training, but I feel it's very reassuring that we intervene, we can do something at the beginning, and our patients will benefit long term. That would not have necessarily to be the case. Sometimes we could just stop treatment and the effect goes away. It fades out. It does not. Whatever we achieve in the beginning, that's actually what we see in all the actual trials. So tamoxifen versus NIL, that was statistically significant. One of the big 198 comparisons for AI versus tamoxifen. And other than that, it's just monarchy. As we have seen, I mean, Ru had a wonderful 15-year results presentation of soft and text, and I had the privilege to discuss it. Eventually, there is no mortality difference outside specific subgroups of highest risk, which I think is what we also do in clinical practice. So that's the most reassuring finding. 2 years of treatment, still a carryover type effect in the long run, which I believe is really the most reassuring message here. So Natalie, different trial, number one, different trial. Number two, 3 years versus 2 years. And we keep discussing it in the clinic. I had a lengthy discussion with Dennis Lehman, who told me that he was fighting for 5 years because he strongly believes, it's speculation, it's scientific assumption, we cannot prove that, but he strongly believes that to keep these dormant tumor cells, these sources of recurrence in check, keep them in a quiescent state, we need to have the cell cycle inhibition for as long as possible. So eventually 3 years is what the Natalie colleagues eventually settled with Novartis. Third difference, backbone endocrine treatment, solely AI here. And one of the issues with monarchy is that some of the effect appears to be driven by tamoxifen. It's kind of counterintuitive to use tamoxifen in a high-risk population, in addition to the thromboembolic event concern, but so almost not all, but almost all stage 2 patients were eligible for that trial. However, as I will show you, our colleagues recruiting into Natalie did an excellent job. So that's the IDFS, a little bit less mature, but you see very same effect. 3 years of treatment, curves keep separating thereafter, which I find is an excellent result. Subgroups, we are trying to identify subgroups for whom a treatment is more beneficial or not beneficial at all. And usually in these large trials, we don't see any signal in the forest plot since overall survival is immature. Distant metastases are used as a surrogate parameter, and you see that there is a difference between the groups here, the different organs of metastases. And what is also very important is that because it is extending towards the not negative subgroup, to look at, well, is the effect there minute or is it reasonable? And I think it can be said it's reasonable. What is, to me, an interesting observation is that's the 5-year IDFS risk of the not negative subpopulation in Natalie, less than 85%. That's much worse than my not negative patients do at 5 years. So it indicates that our colleagues in those sites were wisely choosing the not negative patient. That's not every not negative patient. It's high risk not negative patients, which is probably the right thing to do. Over survival, immature, currently like a 1.6% benefit. Novartis would love to have statistical significance. I think most people can interpret hazard ratios, all that. That's John Crown's summary slide from ESMO in Berlin. Eventually a clinically meaningful benefit. Briefly, when we escalate treatment, we also have to discuss tolerability and side effects, quality of life. Everybody knows abemaciclib is causing diarrhea. We usually say it's well manageable. It is for the majority of patients, not for every patient. When you're a primary school teacher or a Uber driver, might be a little bit difficult even to have grade 2 diarrhea, but in principle, it's not a total obstacle. And I have already discussed the thromboembolic event situation, particularly because part of the Monarchie effect apparently is driven by the tamoxifen subgroup. And I realize it's a global trial. There's different cultures of endocrine backbone. For example, in Japan, almost everybody gets tamoxifen, even in higher risk subgroups. But that's something that we might discuss. Eventually, and it took me forever to find out what is the true discontinuation rate in Monarchie. I asked Steve Johnson, I asked Nadia Habeck, I asked Joyce Connerty, I asked Lilly Europe, I asked Lilly Global, and eventually I found it when I was reviewing a paper for Annals of Oncology on page 72 of the supplement. So that's the difference between academic and industry-controlled research. It's 30%. So it's not that low. It's not everything is due to adverse events. And yes, we are struggling with keeping our patients on treatment. And as I will allude to, and in the end of my talk, I think we need to shift our focus to drug adherence a little bit more rather than keep inventing new innovations, because in clinical practice, that's really an issue. I mean, approximately 10% of patients stop their treatment every year and just the endocrine treatment. And now we're 30% here, 36% in Natalie, 46% in Paula's early discontinuation. That means that we are not doing a very good job in supporting our patients in, staying on the drugs, that life-saving drugs, I should say, that we prescribe. And obviously, it's a matter of time, a matter of communication. I mean, the best way to destroy your drug adherence if the patient starts complaining about some side effects affecting her quality of life, sexual life, whatever, and you say, well, you have to cope with it, that's how it is. Boom, the patient will just stop and probably not tell you the next time. So it's a matter of our attention and communication. Quality of life in Monarchie eventually is good. So safety data for Natalie, you realize that the dose reduction from the Mona Lisa set of trials, all of them showing overall survival benefit, was helpful in eliminating the QTc issue more or less, so bringing it down to 0.2%. Again, quality of life data available also for this trial. Not much of difference here, and that's a summarizing slide on all of the side effects in Natalie. Dose adjustment is an issue. The most frequent cause of discontinuation actually in Natalie was transaminase elevation, so transaminitis, which is quite different to the clinically more disturbing diarrhea with abema. But eventually it means that you have to choose with your, to me, it's relatively easy because I'm a clinical trial aficionado, so we'll always prescribe in my practice what has been defined in the trials. And there is differences in the backbone endocrine treatment. There's differences in how long after the beginning of the endocrine treatment you can use it. It's 12 weeks for abema. It's 12 months in Monarchie. However, I learned that the reimbursement in Australia ends at 6 months after the initiation. Why 6? Why not 5 or 7.2 or any of that? But I'm struggling with the Australian reimbursement policy actually, but also with that crazy idea of if I use it in the adjuvant setting, I cannot use it in the metastatic setting. And some physicians might actually hold back, which I think is against any knowledge we have gained in breast oncology. Use your best interventions first. I mean, why would I not? Also I know you're not the government, but from a cost effectiveness point of view, the most expensive patient by far is the metastatic patient, of course. So if I can prevent a single metastasis, I would put all my money there. But anyway, that might be true for many other early breast cancer interventions. So let's talk a little bit about the future. Most of you are way too young to remember what I remember, that after aromatase inhibitors and fulvestrant, it was said, well, that's it for endocrine treatment. We have tamoxifen, we have AIs, we have fulvestrant, no further development. Well, not quite. We are seeing now, I think, about 35 drugs in late phase 2, at least. SERDs, PROTACs, CRAs, CERCAs, and I'm not even adding the CDK4, CDK2, triple bispecific, whatever things that will come. And I have to say, I was really surprised and amazed in part by the risk. In this case, the big companies who are taking, I mean, this is 30,000 adjuvant trial patients on a slide, and all that investment started before the first piece of metastatic breast cancer data of SERDs was presented. Apparently, that works. We're going to have quite a number of trial results in the next 24 to 36 months. We saw the first study, the pioneer, as always. Also, you can criticize, there is no CDK4/6 there. The lidERA study was presented in San Antonio. I believe, to the surprise of many, at least definitely to my surprise, the 0.7, I would not have expected such a magnitude of difference. However, remember what I said about intervening early and persisting benefit in the long term. I think it's reassuring to see that, because we can hope that what we gain in the beginning with the SERD is maintained also long term. Whether that works in the combination or addition of CDK4/6, I think is a question that will be clarified by the Cambria set of trials, by EMBER-4 eventually. We believe in the endocrine responsiveness, not so easy to implement. We actually have starting 2 trials in parallel, because doing clinical trials is the best way to change a national standard of care. We implemented RCB instead of PCR for the neoadjuvant assessment by doing trials, and we are doing so for the endocrine responsiveness. I believe that that's a good concept that the West German study group brought to the field. As a matter of fact, it's very rare that an Austrian says something nice about the Germans. We have that little brother, big brother thing going on, but that's really an addition, because it's an individualized response predictor, and you can potentially spare an additional group of patients chemotherapy. Even the usually conservative St. Gallen panel approved or endorsed this. It's a good idea to have such a treatment. This is the one of my favorite trials, the toughest one, chemotherapy versus endocrine treatment, communication-wise with patients. I've done this 3 times in my life. That's the toughest challenge, to convince someone to be randomized to chemo or endocrine. Again, based on 3 to 4 weeks of endocrine pretreatment, endocrine responsiveness testing, plus ctDNA level. We strongly believe in this. I already alluded to that. I think the new assays become so sensitive that we even have to consider whether negative is necessary or ultra low is good enough to identify low risk. I should not give a presentation at Peter Mac without quoting a work by Sherin Loy. That's the early Monarch E ctDNA data, showing excellent prognostic differentiation with the presence or absence of ctDNA in an early test. However, it's all coming from the first 2 years. And I think that's indicative of something that, that would be what we usually would think we address with adding chemo or escalating cell cycle inhibition. It's not so much a third thing here, because after 2 years, these curves are parallel or even a little bit more patients in the baseline ctDNA negative. Now, what to do with that? Obviously, we don't know. That's a question my friend Hal Burstein put to the St. Gallen panel in last March. Triple-negative breast cancer, PCR, but some MRD test positive. What are you doing? And you see that these global experts, wonderful people, 40% of them says we treat somehow. Boom, pembro, and capecitabine. No evidence whatsoever for any of that. But it shows our desire to do something with these patients, because we are concerned about them. And actually, very recently, I had a conversation with a very educated academic patient of mine, and she read something about the MRT testing and all of that, and ctDNA, and she said, can I do such a test? And I said, well, we're not doing it routine, and we can try to find access for you if you wanted it. Then she said, well, if it came back positive, now I'm in follow-up 6 years after surgery, what would we do? And I said, well, nothing. And she said, then I don't want to know. And I think that shows our dilemma. We need to identify, number one, we need to optimize the analytical and technological and eventually also the cost of these assays. Number two, we need to identify, is it helpful to know? Number three, if we know, can we do something about it? Because otherwise, let's just not test. I mean, there's a reason why we are not doing regular 3-monthly tumor markers or whatever, for the very same reason. So that's going to be important research. We will try to keep learning about this. I'm pretty sure it will find its way into routine practice, but how, I'm not so sure. Now, another Chinese result I think is interesting. We can further subtype luminal breast cancer. So the Fudan multi-omic classification, and these guys are doing that in routine practice. That's really impressive, I can tell you. Identifying further subtypes of patients who would be particularly responsive to CDK4/6, identifying a small but relevant subgroup that might actually need a checkpoint inhibitor, which we're not usually using in luminal breast cancer. So also the traditional research perspective in further subdividing groups by molecular or in this case, including proteomic. And pretty soon it will be artificial intelligence helping us to sort all of this out. I'm not sure how the robot will tell the patient that she is at high risk, but other than that, I think the good conclusion is physicians who know how to use AI will be better off than physicians who don't. Eventually, we need to, I think, try to refocus ourselves on involving patients in this shared decision-making and avoid a setup as it's in this cartoon, because all of these questions eventually need our patients for their final decision. That's a slide I developed for my ESCO discussion last year and trying to describe the escalation pattern if there is increased risk, in this case in primary patients. And what you can see is that, and that's also was in some of the votings of the Sangal meeting, we would like to do something with CDK4/6 inhibitors, particularly for those intermediate risk patients, where we sometimes, when there's this luminal disease, give chemo, not because we are convinced that the chemo is so effective, we're giving it because 5 positive nodes, lobular, chemo might not work, but out of despair, we give it. No evidence until now. We have to wait for other cycle and similar trials. But, if you ask me to give a, prediction of the future, I would say 5 years forward, we will use the CDK4/6 inhibitors instead of chemo rather than on top of chemo, except for the very high risk. But we need to find out. Every time I believe something very strongly, I was wrong. So I have to be careful with that. Believing is the enemy of knowing. However, refocusing in closing on side effects and tolerability, we know this is wonderful data from the pivotal soft and text trial, and we know that vasomotor symptoms can be really terrible for young patients, particularly in the combination with ovarian function suppression. And potentially in male-dominated medicine, I think there was overlooking this for much too long. It's not trivial when you have to change your T-shirts 5 times per night. And I think we need to focus our attention on that, because actually the dose interruption and the discontinuations directly translate into outcome deficits. That's excellent real-world data from France, published in JCO last year. And you see that depending on age a little bit, so the younger patients are most vulnerable, but you can count the percentage points from with discontinuation and lack of drug adherence, how this translates into deterioration of outcomes. So for those affected severely with vasomotor symptoms, hot flushes, night sweats, I think a new class of drugs might be helpful. Neurokinin targeted antagonists, NK1, NK3 receptor, now tested elisanimab also in breast cancer. Fatima Cardoso presented it at ASCO, published in the New England Journal, now approved. In my country, not yet reimbursed, but we are fighting for it because we believe for those patients suffering the most, that would really be very convincing data. Eventually, working together will move us ahead We have been successful. In my country, we have eliminated 1/3 of the breast cancer mortality in the last 25 years. But we still have work to do, and we do so by working together and by focusing on our patients. That's one of my favorite paintings, self-painting of one of my patients. Whether in research, whether in the laboratory or in clinic, or with clinical trials, that should be the overall focus of all we are doing. I skipped the summary because we talked about everything, and I'm looking forward to your question after saying thank you to the best team in the world. This is APCHG's wonderful team, and hope to see many of you in March 27 in Vienna for the next edition of the St. Gallen Conference. Thank you very much for listening.
Thank you. Fantastic talk. I'm sure we have lots of questions. Do we have some online?
There are questions online thus far.
Can I see them somehow here? Any questions from the room? Prue?
I guess we've had many thousands of patients in randomised ribociclib trials in the adjuvant and metastatic setting, and I guess a lot of baseline blood taken. Are there any predictive factors that can predict the hepatic toxicity, which you said was the most common reason that patients discontinued adjuvant ribociclib? Is it thought to be underlying, pharmacogenomic differences? Is it an autoimmune phenomenon? Is there any clue that we could predict?
Okay, so not that I'm aware of. It's but it's the same like we discuss pneumonitis in ADCs, and it's very same. You would assume that with tens of thousands of patients treated, we would find something. I mean, we are obviously more cautious in patients with pre-existing liver disease. Austria is a country full of vineyards, so we have some patients who started baseline with elevated enzymes. But there's excellent wine in Australia and New Zealand as well. So that. But other than that, I don't think there's any molecular other pattern to predict that toxicity. But I agree with you, prediction of toxicity or even tolerability issues. I mean, there are inter-individual differences also with side effects of endocrine treatment, as you very clearly know. That would be an important line of research in the future, not only about differential efficacy, but also about tolerability.
I've got a question. You made a comment, not about the CDK inhibitors, but it was about the use of neoadjuvant endocrine therapy in general. And we're aware of some of the trials that suggest that a good response, Ki-67 fall, implies low recurrence score, no need for chemo. It's not being used routinely in Australia. Is it in Austria? And should it be?
I believe it should be. It's not yet. I mean, we have these two parallel trials trying to implement that. When we started doing the whole neoadjuvant endocrine field is hindered, I think, by the success of neoadjuvant chemo. I mean, we were fighting for 20 years to convince us surgeons that we should do primary surgery for everyone. Now, once we are there, surgeons got used to PCR. That's wonderful for breast conservation, for many other things. There is not a lot of PCR after neoadjuvant endocrine. And the sentiment about the neoendocrine is always Mike Dixon doing this for 95-year-old comorbid patients instead of surgery and all of that.
Yeah, but if we do routine Ki-67 on core and sample, you've sort of got it's not PCR, but in a way, it's a very useful, reassuring, and we don't have funded oncotype or other gene expression profiles. I guess it surprises me that we haven't taken it on. I'm not sure whether I should be surprised.
We're in a very similar situation. I'm fighting since 3 years now to have, better popularity of this approach. It's not so easy. You need more biopsies. You need to convince the patient that the 3 weeks is not hurting her and all of that. Now we are getting there. And I believe it's going to be, until we have something blood-based or plasma-based, predicting the endocrine responsiveness, it's actually a pretty good predictor. And we are not even, the Germans used it to spare chemo. We are not using as much chemo anyway, but I think for being confident that we can do an neoadjuvant approach like this without harming the patient, I think it's very helpful. And this is our two safeguards. We want to see Ki-67 drop below 10%, which means good responsiveness. And we want to see absence of circulating tumor DNA. So that's the safeguards, how we spare these patients the chemo they would otherwise get.
Anita.
Michael, you've shown, thanks, compelling data about the role of the node or status still in those luminal A's. How have these de-escalation trials, such as SOUND in SEMA, how does that influence your management in Austria? Have you been affected because will we move on to ctDNA instead of looking at central node to sort of...
The problem with the node is that for the first time in my life, I feel old, like a dinosaur, because I find myself on the more conservative side of the argument. I think avoiding a 10 minutes, almost zero morbidity extension of a surgical procedure is almost crazy or is surgical fashion. Come see me because I will not touch your armpit. That's what surgeons in competition say, and I don't like that. And even in SEMA, the shoulder morbidity very accurately assessed. It's a wonderful trial, and all the appreciation for Thoralf and the other colleagues who did it, but it's less than 10%. And, so what are we really sparing our patients? And I tell you what I live in a privileged setting, meanwhile, of, a private situation. I have enough time, I have educated patients, because it's an exchange. And I ask my patients, do you want the sentinel node if they are candidates? Smaller than 2 centimeters, G12, older than 50, receptor positive. Or do you want to have de-escalation of radiotherapy? Because we do partial breast flow, we do 5 days, we extrapolate fast forward to these patients, an overlapping candidate population. And personally, if I have a reasonably experienced surgeon, I would rather have a sentinel node than whole breast irradiation for 25 days, which is the standard. There will never be an INSEMA 2 with partial breast. So what I do, I think nobody does a traditional axillary clearance any longer, but I'm not doing this since 15 years. We learned to protect the lymphatics that drain the arm, we learned to protect the intercostal brachial nerve, and all of that. The morbidity figures, even of Amaros, 15% level 3. When was the last time you had a level 3 axillary dissection? With the exception of Gross disease. 10% wound infection. I don't have 0, but we have maybe 1 wound infection per year. So axillary surgery has changed. What I do post-neoadjuvant is I went back to what the old British teachers were calling sampling. I take 5 nodes because it feels much more comfortable to have 2 out of 5 than 2 out of 2. And then all the discussions start going on, do we go back? Well, second surgery for staging, that's a dinosaur. We are not going to do it any longer. But just to avoid it, because it's so fashionable to avoid it, I don't like it. And in all fairness, I think the patient should decide de-escalation of radiotherapy, even omission of radiotherapy. We have well-defined situations where we can do that. Unfortunately, I have the privilege of having wonderful younger generation radio-oncologists who are not offended if someone says do less, but we will discuss with the patients.
Can I add to that? I think the other useful discussion is in the patient who is not tolerating endocrine therapy well, knowing that she's either node positive or node negative can help her make a decision about how long she will keep going for. And you don't know that at the time of making a decision about whether you are happy to manage this patient in the absence of information about the nodes or with that information. And I've not heard that mentioned, but I think it is a real thing.
Yeah, I agree. And we all have a patient who, after a sentinel procedure, either has a prolonged seroma or wound infection or pain, protracted, and then we say, would be so wonderful. But in a broad range, it's a minimal procedure, right? So I think we should be mindful about what we're doing for ourselves and what we're doing for our patients.
Okay, Jeff, then Shirley.
Thanks, Michael, for a really great presentation. So my question relates to the profound cell cycle arrest that you referred to and the fact that these cells are probably sitting in the bone marrow. What do you think is actually killing these cells, and where do the bone modifying agents fit in, given your own interests in denosumab and zoledronic acid?
I mean, you asking me a question about the bone? Okay, that's fine. I'm always up for a challenge. I think the problem we have with the anti-resorptive agents is we originally developed them as cytotoxic agents. And that's not how they work. They are microenvironment targeting drugs. And since I'm a surgeon by training, I'm a simple-minded person. I can also only give you a very simple example. The surgeon is at night shift and, until 4 a.m. and then falls into the bed and the alarm goes off at 6. And you wake up and you have to make a decision. Either I keep waking up or I turn around and and that depends on the environment. If your wife is there, there's coffee, and everything is warm and nice music, then you will rather wake up. If it's cold, nobody there, hostile, this is what we do with bisphosphonates or anti-rank ligand. We deprive the awakening cells of a fruitful environment. So, can I prove any of that? No, but that's my hypothesis around it.
At what level of risk would you not use a bone modifying agent? Because I guess here in the postmenopausal setting, there's
we have been struggling in identifying the long-term benefit of DMAP, as you know, because Amgen didn't particularly like that. It cuts fractures in half, much better than bisphosphonates. And as you know from our New England Evidence paper, 22 paper, it's sustained in terms of even with the methodological challenges in terms of the long-term outcome benefits. So I offer it to almost every patient. Maybe not to a patient with severe dental work ahead of her or 96 years old or already atypical fractures. But, at 60 milligrams every 6 months, we now in ABCSG 18 look at 10,000 women treatment years. And we had one atypical fracture. The FDA was all over the place, but that was a patient who hit the concrete wall on a skeleton. That bobsled thing with the head, and she broke 50 bones in that accident. She barely survived, but one of them was a subtrochanteral femoral fracture, which is considered atypical, and the FDA flew in and said, this is denosumab caused. Hitting a concrete wall at 60 miles per hour, to me, is adequate trauma, okay? But you know that. So I don't know whether either of that is true. That's I think targeting the microenvironment might be even the eventually more successful approach than trying to target the dormant cells themselves. We have all these, better than I do, the stem cell markers and all of that. But the problem with a sleeping guy is you cannot really disturb a sleeping guy. So their metabolism is down, they're all quiet. And once they wake up, we need to be there. So why not take the detour about the microenvironment targeting, which I think what we do which is why everything works at low dose. And it doesn't work at high dose because it's not a cytotoxic drug.
Other questions? I thought you're pointing out that the poor performance in the placebo in, I think it's Natalie in stage 2.
Yeah.
Goes to your discussion about high risk and low risk stage 2. Do you have a definition of what is high risk?
Well, yeah.
Because the issue is, we have these guidelines that if certain pathologies met, then a patient is eligible. It feels to me as though many who are eligible are low risk. and it's important that we identify high risk if we want to use these drugs wisely.
I agree with you. I think, I can give you 5 slides with high risk features, but what it is, I think we all agree what the low risk patient is, and we all agree what the high risk patient is. The question is, it's not quite low. You have some indicators of increased risk. I prefer the term increased risk. It's either lymphatic invasion, or it's a luminal, but the Kia 67 is 28%, or a test that it comes back at 21 recurrent score or something. So it's these indicators of this is not a flat low risk. I think these are the patients who should be considered. I'm not saying all not negative breast cancer patients should have adjuvant ribo, because it will translate into different absolute benefits, and then we discuss it with the patient. And yes, we all have patients who say, give me 0.8%. I'm a young mother of 2, and I do everything, and I don't care about my liver enzymes or diarrhea or whatever. And we have other patients who say, for 1.5%, doctor, you can keep that. But are we as strict with the indication for chemo? There's still so many young patients giving chemo on the misinterpretation of our responder. Because the Americans believe that 2.3% benefit in the intermediate group is good enough, and they only use ovarian function suppression in 13% of the endocrine-only group. With a treatment that IBCSG, or actually Ludwig back then, has defined as 12% absolute benefit. I'm not giving chemo to any of these patients. So are we as restrictive with chemo as we are other drugs? And that's the more massive intervention into our patient's life.
It's great to have someone who is very provocative to make us think. Other questions? We've probably got, I guess it is 1:30. If no further questions, were there any questions online?
No, nothing online.
Okay, just thank you, Michael, for coming, for sharing these thoughts. Great talk, very provocative, good discussion. Enjoy your time here.
Thank you.